Hello and good morning. We are going to start our webinar session organized by the Knowledge Hub, the FCTC WHO Waterpipe Tobacco Smoking Knowledge Hub. Thank you for joining. Our topic today is cardiovascular and respiratory health impacts of waterpipe tobacco smoking. I'm Rima Nakash. I'm the co-director of the hub, and I will be facilitating the session. Our speaker today is Dr. Hassan Chami. He's associate professor at AUB Medical Center in Pulmonary Sleep Critical Care Medicine, and he has a master's in epidemiology. He will be presenting on this topic for half an hour, and then we will open up for questions and discussion.
I guess that's my turn. Thank you, Dr. Nakash. It's my pleasure to be here and to be presenting in this seminar series. Working? We got over the echo issue? Okay. So the title of my presentation is the cardiovascular and respiratory health impact of waterpipe tobacco smoking. I'll try to speak within the half hour, although I have a lot to cover. And this is the outline that I'm going to follow. I'm going to start first with a review of the waterpipe smoking epidemiology, and then start by tackling the association of waterpipe smoking and coronary artery disease, the association of waterpipe smoking with some of the important hemodynamic measurements, including arterial stiffness, lung function, COPD, and then summarize with the evidence limitation and talk a bit about future direction and what still need to be done in that regards. So as you're all well aware, smoking rates are very high in our region. I used to think that the highest smoking rates are in Jordan, but unfortunately, it turned out that in Lebanon, we, this is not showing here. Okay, no, it's showing. All right, so we have the highest rates of smoking according to this survey in individual more than 40 years old, reaching above 50%. Now, traditionally, waterpipe smoking had occupied a small share of the pie in older individual. However, with the more recent surveys in younger individuals, such as this Global Youth Tobacco Survey in individual 13 to 15 years old, the rate of waterpipe smoking were quite elevated, reaching up to 35% in Lebanon. Now, waterpipe smoking is not a problem only restricted to the Middle East and the Arab world. Several surveys from around the world show very high rates of smoking also in younger individuals from Europe, Eastern Europe, Central Europe, and different countries in the world. Nevertheless, the evidence linking waterpipe smoking to several diseases, importantly coronary artery disease and respiratory diseases, which have been causally linked to cigarette smoking in previous studies, is quite weak. When we first looked at the literature more than 10 years ago, the only study was in case report or case, abstract form, and the first publication was only in 2012 from a hospital-based study of about 8,000 individuals who were hospitalized with acute coronary syndromes in hospitals from 6 Arab countries, and showed that exclusive waterpipe smoker had 2 times the odds of hospital mortality compared to non-smoker. And they also had higher rates of recurrent ischemia compared to cigarette smokers. Studies from the large Golistan cohort from Iran of about 50,000 individuals also showed that heavy waterpipe smoker had about 4 times the odds of having self-reported heart disease, Moderate smokers also had about 2 times the odds of self-reported heart disease. The problem with this study is the recall bias, self-reported heart disease, and not with no real clinical assessment, the low number of waterpipe smokers, and there was a lack of adjustment for some important risk factors. Another community-based studies from Bangladesh showed increased risk of heart disease in waterpipe smoker, including significant concurrent cigarette smoking, which is an important limitation. So about 99% of waterpipe smoker in the study smoke also cigarettes or another local tobacco modality is called bidi. So it's really hard to tell and isolate the effect of waterpipe smoking. And another hospital-based study from Lebanon that looked at coronary artery disease diagnosed through angiography also had a high proportion of significant concurrent cigarette smoking and ex-cigarette smoking, so same problems. So we can see that we're having an increase in the number of studies tackling this problem. However, the data is quite limited, mostly cross-sectional studies, quite a bit of concurrent cigarette smoking. There's lack of adjustment for important confounders, and selection of hospital-based samples, which could bias the results in some of the studies. In order to address some of these limitations, we thought that we would want to evaluate the association with waterpipe smoking and important health outcomes such as coronary artery disease and exclusive waterpipe smoking from the community. Also use a validated or validate a survey tool for assessment of waterpipe smoking, which was not available. And ideally establish a well-characterized cohort for prospective evaluation of these health outcomes. Now, since it's quite impractical to wait for the health outcome to occur, and we needed evidence to back our policies more quickly, we thought of looking at validated predictors of incident coronary disease and pulmonary diseases. And we set up our study in with a first phase where it's a cross-sectional analysis, where we compared markers of cardiovascular and respiratory diseases in exclusive waterpipe smoker and non-smoker recruited from the community. And hopefully at a later stage, we'll have reassessment for incident health outcomes. Our primary outcome was the coronary artery calcium score, which is a validated predictor of cardiovascular events, and it's an independent of other risk factors such as the Framingham heart risk score. We also looked at a slew of other secondary outcomes, and these include arterial stiffness, which is also a predictor of incident hypertension and coronary heart disease and mortality. We evaluated the percent of emphysema on the scans we obtained to get the Cac score, and also measured airway obstruction using spirometry and also impulse oscillometry in a subset, and we'll talk about each of those in details. We also had assessment for other metabolic markers and inflammatory markers, oxidative stress, urine microalbumin, and serum creatinine levels. Our study timeline was initially 3 years, but we extended it for 4 years. We had 2 sites, one in Beirut, one in Doha, Qatar, and we recruited our participants primarily from cafes, waterpipe smoking cafes, and advertisements. We had exclusive waterpipe smoking and non-smoking control, and our goal was to get 110 waterpipe smoker and 110 waterpipe non-smoker from Beirut, and a similar number from Doha. Our inclusion and exclusion criteria were quite strict. We looked at participants more than 40-year-old, and we excluded any individual who smoked cigarettes or other tobacco modality. We also excluded pregnant individual with diabetes, renal failure, because they impact the coronary calcium, and also individual with non-smoking related lung disease such as asthma, bronchitis, or fibrosis. The controls were never smokers, so they never smoked cigarette, cigar, or waterpipe or any other modalities, and had similar exclusion criteria. For recruitment strategies, we faced many difficulties and we had to use many recruitment strategies. We went directly to Waterpipe smoking cafes in towns, and we also did quite a bit of campaigning on social media, Facebook, and we didn't have Instagram back then. We distributed posters, flyers, summary card, and even used newspaper advertisement. We were able to reach our target enrollment in Lebanon. However, recruitment proved to be more difficult in Qatar, so we had to enroll 50 additional participants in Beirut to make up for the shortage, and we still came up short 36 participants. The total number of participants at the end was 404, and they were, like I said, evenly distributed between smokers and non-smokers, and we matched our smokers and non-smoker to age groups and sex, so as to adjust for these important confounders. The study's procedure started with an informed consent, and then we used the Waterpipe smoking questionnaire that we validated. We measured height, weight, blood for every participant. We performed the tonometry and vascular measurements to get the Augmentation Index and arterial stiffness. And we did the chest CT, which gave us the coronary calcium score and the percent emphysema, and sampled blood and urine for biomarkers. And finally, we did the pulmonary function test, and which includes spirometry and the impulse oscillometry. Like I said, we were able to validate the Maziak questionnaire, and with that, we were able to confidently use measures of Waterpipe smoking intensity, the pattern of use, duration, and the overall lifetime extent, which was calculated by multiplying the number of Waterpipe smoked per day times the number of years of smoking duration. We also used the serum cotinine level to validate this questionnaire and to assess the smoking intensity. For the primary outcome, we had a pretty even characteristics for the samples. So we had about 175 Waterpipe smoker, 170 non-smoker. We had to exclude a few participants who had placed coronary stents, and these coronary stents were metal, and it would be very hard to measure the exact coronary artery calcium in these patients. So we had to exclude about 6 individuals. But following our matching strategies, the age and the sex distribution was pretty even. Body mass index was similar. So Waterpipe smokers were a bit more likely to use lipid-lowering medication, and we adjusted for that in our analysis. They also were more likely to have family history of coronary cardiovascular disease, and we also adjusted for that. Naturally, the cotinine level was significantly much higher. Unfortunately, about half of the never smokers were actually exposed to secondhand smoking, which could have a bit biased our results toward the null. Like I said, the Cac measurement is obtained through CT, and here you could see the calcium deposits that we're able to detect over the coronary artery. Here we're seeing the left anterior descending artery, and we're able to quantify that. And this is a very powerful tool, because if someone doesn't have any calcium deposit, they pretty much don't have atherosclerotic disease, and it's a good predictor that this person will very unlikely, almost 0% chance that they're going to experience a heart attack in the next 5 years. So this is very powerful. On the other hand, if the Cac score is quantified to be above 100, then the risk of having a cardiovascular event in the next 7 years was estimated to be 7-fold higher. And you can see that in this study where they compared the coronary artery calcium score to traditional risk factors, if someone has a coronary artery calcium score of more than 100 in yellow or more than 300 in red and no risk factors, then the risk of incident cardiovascular event is more than 3 times the risk of the person who's CAC 0 and has 3 traditional risk factors. So this is even better than asking the patient about their family history, about whether they smoke, whether they have diabetes, or their cholesterol is high. And we published our main outcome just recently in CHEST. I'm just going to go over the main findings. Basically, the CAC score was significantly higher in Waterpipe smoker here in blue. You can see it compared to non-smoker. And we saw the same trend that didn't reach statistical significance in all coronaries, but even in individual coronaries, the left main, LED, circumflex, right, you could see that the calcium score is higher. The percentage of patients who had calcification was also higher, 41% in Waterpipe smoker compared to 28% in non-smoker. And if we look at those who have a CAC score above 100, then we also see the same pattern where 17% of Waterpipe smoker had a high CAC score compared to non-smoker. And the findings were similar when we use percent predicted CAC score, where individual in the highest percentile were about 20% of Waterpipe smoker compared to 10% in non-smoker. We ran regression models to adjust for the possible confounding of some of the important predictor of coronary artery disease, and we found that even after adjustment, Waterpipe smoker had 2 times the odds of getting a coronary calcification, and about also 2 times the odds of getting an significantly increased CAC score above 100. And the findings were also similar when we looked at different ways of quantifying the coronary artery calcium score using absolute or percent predicted values. We even looked at the extent of Waterpipe smoking, and we found that the extent of Waterpipe smoking measured in Waterpipe smoking duration, number of Waterpipe smoke per day, or the whole lifetime extent in Waterpipe years was also associated with the extent of coronary artery calcium and the coronary heart disease risk using the MESA calculator that takes into account the coronary artery calcium score. So in conclusion, in a community-based samples of asymptomatic individual, after adjustment for confounder, we found that exclusive Waterpipe smoking had a higher coronary artery disease risk compared to non-smoker, measured by a validated predictor, which is the coronary artery calcium score. Another important measurement, hemodynamic measurement, is the arterial stiffness. I'm not going to go into a lot of details on how to measure it, but basically, the stiffer the arteries, here we see the aorta, then the quicker that the arterial pulse wave would travel along it. So we're able to measure this velocity, and it's basically correlates with the arterial stiffness. Another important phenomenon is that when these waves reach down the branches of the tree, they get reflected and they move backwards, and then they meet the incident wave and augment it, so the pressure is even higher on these arteries, and this is called the Augmentation Index. And we can see that the reflected wave usually hits after the incident wave in a young individual, but the older the person is and the more vascular disease they have, the stiffer the arteries, and then the reflected wave would meet the incident wave and augment it, and then the pressure becomes a bit higher on the vasculature and may contribute to coronary disease. This is an important measurement. Again, it's called the Augmentation Index, and it measures arterial stiffness and wave reflection, and it's associated with cardiovascular risk. It can predict the presence and the severity of coronary artery disease. So several studies had looked at the hemodynamic parameters in Waterpipe smoking, and here I'm showing the results of a recent study showing that blood pressures, both central and peripheral, is increased after acute exposure to Waterpipe smoking, and that these augmentation index would go up after the patient smoke Waterpipe acutely, so right after they smoke Waterpipe. However, there's no previous studies that looked at the association of waterpipe smoking is a sustained increase in arterial stiffness. So we looked at that in our samples. We had about 400 participants who had tonometry, and we found out that the augmentation pressure and the augmentation index were higher in smoker compared to non-smoker after adjusting for a large number of possible confounders. Here we see the augmentation pressure, and here we see the augmentation index. However, another measure of arterial stiffness, which is the pulse wave velocity, was not different. We also looked at the extent of waterpipe smoking, and we saw that the augmentation pressure and augmentation index correlates significantly with the extent of waterpipe smoking in years, number of waterpipes smoked per day, and even with cotinine level after adjustment for confounders. So we also concluded that in addition to coronary artery score in this community-based sample, and after adjustment for confounders, asymptomatic exclusive waterpipe smoking had increased augmentation index compared to non-smoker, which suggests also that they are at higher risk of incident cardiovascular events. Now, moving on to respiratory function, we also know that there's quite a bit of studies that looked at the association of waterpipe smoking with lung function. They were primarily community-based. We could see the studies here listed. Most of them showed that lung function is impaired in waterpipe smoker compared to non-smoker, or similarly compared to cigarette smoker. However, they also limited by cross-sectional design. There's lack of standardized waterpipe smoking assessment, and most of them didn't present detailed spirometric measures, and there was no adjustment for confoundings. This has been reviewed also in a meta-analysis published in 2011 by Dr. Ael Andrade and their colleagues, and they concluded that FEV1 is significantly reduced in waterpipe smoking compared to non-smoker. The FEV1 is basically the ability of the patient to exhale most of the content of the lung in the first second, and if this is reduced, then it means that the breathing pipe is smaller, which happens with waterpipe smoking and condition called chronic obstructive pulmonary disease, so COPD. There's another measure, which is the ratio of this FEV1 over the total lung capacity, and it's also been shown to be reduced in this meta-analysis, suggesting that individuals who smoke waterpipe are more likely to have a narrow breathing tube. Now, we also looked at the lung function using spirometry in our study, but we thought of doing something even more cool. We looked at a newer and more sensitive modality to measure lung function called impulse oscillometry. So instead of blowing into a tube and measuring how much the patient is able to exhale in the first second, this machine actually sends sound wave down the breathing tube of the patient, and these sound waves get reflected and measured back. And depending on the frequencies that they are measured, the reflected wave are detected by flow and pressure transducer and are analyzed to calculate the airway resistance and the reactance of the lung, which is the ability of the lung to recoil. So they're able to measure the airway resistance and how much there's recoil and elastic component in the lung. And these measurements have been shown to predict COPD severity. So they're able to predict how bad the disease is. And as you can see in these graphs, the very severe has very high resistance compared to those with who are normal. And the other measure, which is X, which is the reactance, is much lower in the very severe. It's a negative measure, so it's much lower in the very severe compared to the normal. Interestingly, iOS is able also to detect early respiratory dysfunction in individuals who have symptoms but have normal spirometry. As you can see, there's the here in green, the sorry, where is it? So the questionnaire is Q plus here and G minus. So G minus is the spirometry. So here in pink, there's higher resistance in these individuals who have symptoms, but their spirometry is normal, which was not detected by spirometry, and similarly using the reactants. Now, in our samples, we were unable to do IOS in all the samples. We did it on 200 individuals in the Beirut site. And in these 200 individuals, we had about an even split between waterpipe smoker and non-smoker, and they had similar lung function using spirometry. So there was no difference. And you can see it's about 100% predicted in all. And when we surveyed them for symptoms, very few, actually only 2 report dyspnea, 1 reported emphysema. So these a very asymptomatic bunch, about 200 individuals on whom we ran IOS. So no cough, and just 2 who had some dyspnea, and 1 who had emphysema, and none had COPD by history. But interestingly, when we looked at the IOS, we found a significant difference in resistance. It was higher, and the capacitance was lower. And when we adjusted for age and sex and height, which are important predictors, using the percent predicted measures, this association remained present. So the waterpipe smoker had higher error resistance. Some of the other measures did not meet statistical significance. When we also looked at the extent of waterpipe smoking, we also saw that they correlate. So the extent of waterpipe smoking correlates with the extent of resistance, which is also adds to the evidence linking these 2 variables. So in conclusion, even in apparently healthy and largely asymptomatic exclusive waterpipe smokers from the community who, despite having basically no symptoms, were able to detect impaired lung function assessed by impulse oscillometry compared to non-smokers. Now, moving to our last piece here with the waterpipe smoking and COPD, there's many ways to assess COPD. The gold standard is to use spirometry, which is the measure of lung function, and use the measure of FEV1 over FVC of less than 70% as a definition. Now, there's very few studies that looked into that. One of them is from Lebanon, published by Dr. Waked, and it was a cross-sectional community-based studies, including about 2,200 individuals, and it just assessed for possible confounders, including age and cigarette smoking, and showed that waterpipe smoker had 2.5 times the odds of having COPD. And interestingly, dual smoker had even higher odds. COPD. There's a similar association found with the Chinese waterpipe, also published in CHEST, but this is pretty much about it for studies that used the gold spirometry definition. Another way to look at COPD is to look at symptoms of chronic bronchitis using questionnaires, and there's a few studies that looked at that. Most of them are cross-sectional, and they pretty much all of them showed an increased odds of having symptoms of chronic bronchitis, the definition being chronic cough with sputum production for more than 3 consecutive months per year for 2 years. And they looked at different exposure, but pretty much these 3 studies showed an increased risk of chronic bronchitis in waterpipe smokers compared to non-smokers. A third way of looking at COPD is to look at emphysema. And virtually there's no studies that looked at emphysema in waterpipe smoking. Emphysema is usually found radiographically, so you need a scan of the chest to see it. And now there's a new technique that looks at actually the scans and able to quantitate the percentage of emphysema. Basically, the density of emphysematous areas are destroyed lung, so they're full of just air, and the density of air is about 1,000 on scans. So if we look at the volume of low density pixels, less than 950, we're able to calculate emphysema. And studies that correlated the emphysema measured and using these CTs actually found that it correlates very nicely with the degree of emphysema measured on resected lung specimens. So people undergoing resection of their part of their lung for any reasons, if they do a scan before, they correlated the degree of emphysema measured on CT, and they found that it matches the surgical lung specimen. Another important of the quantitative emphysema that it's able to predict mortality in patients with COPDs and also hospitalization in older smoker and incident airway obstruction in older smoker. So which shows that it's a pretty useful test. When we looked at the percent emphysema in our sample, we found that it was higher in waterpipe smoking, although it didn't reach statistical significance compared to never smoker. And when we looked at when we actually adjusted first for important confounders such as age, sex, body mass index, and the study site, we found that this association became significant, and that also the percent emphysema correlated with the extent of waterpipe smoking measured by smoking duration, the number of waterpipe smoked per day, and even by cotinine levels. So also in conclusion, here we found that exclusive waterpipe smoking and its extent are associated with the extent of emphysema assessed quantitatively on chest CT in individual from the community. So this is a summary of what we analyzed so far, and we believe it adds significantly to the evidence that's available. However, we're still limited by our cross-sectional design. We don't have prospective data yet. We hope to reanalyze our sample down the line and reassess for incident outcomes. And of course, we're limited by secondhand smoking, which is very prevalent, unfortunately, in our country, and it affects about 50% of our sample. We still have several outcomes to analyze, and we're working hard on that. And stay tuned for more results. And I'll just stop here and thank my collaborators and the Qatar Foundation who provided funding for this study. And we'll open the floor for questions.
Thank you, Dr. Chami, for the presentation. There are two ways that we can take questions, so we're opening now for questions. There, you can either write the question or raise your hand, and we can unmute you to be able to ask your question verbally. Okay, so I have a question for Dr. Chami. This is very interesting findings and much needed evidence that we need about the cardiovascular health effects of waterpipe tobacco smoking. I would like to ask Dr. Chami about what's next. What are the next research questions that come up that he will be looking forward to investigate?
Thank you. So, like I said, I think the most impactful, study would be to actually replicate these findings prospectively. So, you know, we have this inception cohort. We're trying to recruit additional participants with, you know, maybe not the complete assessments with the scans and all the biomarkers, but at least basic health characteristics, and follow them over time to see how these, you know, their health would change with continued smoking, and how maybe cessation, hopefully, in some of them would also impact. So something similar to the big cohort that tackled the cigarette smoking, such as Framingham and lung health studies and others. We also have other biomarker that, like I said, that we're still analyzing, inflammatory biomarker, to try to investigate better the mechanisms of association. We also have saved some serum, and we have also extracted genetic material from these participants that we're trying to analyze and hopefully try to use up to answer the mechanistic association.
Thank you, Dr. Chami. It seems we have a question from Taheri Simai. So the question is, when patients learn of the results from these types of tests, does this change their water pipe smoking behavior already, or are you saying this isn't yet a study question, but maybe in the future?
I really thank you, Dr. Tahir, for this question, and the answer is very disappointing. As a follow-up to the study, we actually initiated and developed and initiated an intervention for water pipe smoking cessation, which, as you're well aware, is poorly studied. And we tried to recruit some of our participants into the study. And unfortunately, out of the 300 or so participants from Beirut, we were only able to recruit 10. So out of 150 water pipe smoker, we only were able to recruit 10 individuals into a randomized controlled trial and a program fully funded, free, with the even the medication is given for free, and all the behavioral sessions are given for free. And despite that, only 10 out of 150, knowing their results, were interested in participating and ended up participating. And we're still facing significant difficulties in trying to recruit individuals into a water pipe smoking cessation study. I hope I answered your question.
Thank you, Dr. Chami. I think we all know, at least in Lebanon, how much water is socioculturally ingrained and how much there are commercial interests in marketing, how much policy is very weak, and there are misperceptions about the health effects of water pipe tobacco smoking. So maybe there's a lot of research yet to do, or a lot of awareness to do in order to, you know, get those patients more interested in quitting and participating in this kind of research. From my personal experience doing water pipe tobacco control research, it is very hard to recruit water pipe smokers to participate in water pipe related research. So just so that you feel okay about the difficulties that you're facing, I faced the same issues when I was trying to get feedback from water pipe smokers about potential effectiveness of health warnings, of pictorial health warnings. And even though we have a high percent of water pipe smokers, I find it very hard to get people to participate. So thank you for your response. I'm going to check if there are any questions. Catherine? I think Catherine is asking smoking behavior already. Okay. Catherine, if you would like to speak, you can speak now.
Oh, that was my question. So sorry, I sent in the question about that he just answered. That was the one that I typed. So that was my question. Sorry.
Let's go.
Okay, thank you. Sorry for the confusion.
Oh, that's okay. Sorry, that was my fault too. Okay.
Okay, so if there are no further questions, I will conclude and close this webinar. Of course, Dr. Chami is available via email if you have any queries to follow up on this webinar. Thank you for joining the webinar, and please stay tuned for further webinars that are coming up in the next few months. Thank you.